Stefan, du heißt Joachim Oertel.
Ja, das ist komisch.
Ja, wahrscheinlich, weil ich dir das Ding weitergeleitet habe. Okay. Shana, are you with us? Can you send Stefan another invitation? I think the problem is that I forwarded mine.
Oh, okay. Do you have
So this is why we are both Joachim Oertel. This is I don't know if this is going to be a problem or not.
um yeah, I don't know. So the invitation that I have will just sign in at under me, so it'd be Emad that would have to send it.
Oh, okay.
'Cause I don't
Imad is not here, I think.
know, because he made the
Okay,
meeting
then
list.
just leave it. It's no problem. As
Okay,
soon as we don't have any audio problems, I don't think it doesn't matter.
okay, perfect.
Thank you. Nice for being here. Thank you. So, der Dr. Singer, der wartet noch. Sebastian, wir warten auf dich.
Komme von dem Windows-Rechner nicht rein. Ich warte gerade den Mac.
Nee, das geht ganz normal. Was ist denn das Problem?
Noch. Also von meinem Klinikrechner kann ich nicht schauen. Hat bis jetzt immer geklappt.
Aber es ist online. Du brauchst kein Computer, kein Programm runterladen.
Ich weiß, aber ich komme nicht rein.
Oh. Und du hast die Connecting, also du hast alles, das Login und alles?
Dann schick mir es nochmal. Ich habe hier den Click-to Join. Date 21.02 PM von deiner E-Mail-Weiterleitung.
Stefan, hast du den gleichen benutzt, den ich dir weitergeleitet habe?
Ja.
Ja, okay. Ich guck. Moment. Vielleicht lieber auf eine E-Mail, die nicht UKS ist. Vielleicht ist das ein Problem. Ich schicke die mal auf iCloud, hä?
Ich glaube, jetzt geht's, Joachim.
Ja?
Ja. Ja. Ich bin da, ich klick auf.
Okay, perfect. Good. Yes, well, in Germany it's good afternoon. So in the States, Shana, it's what time is it? 10 a.m. I guess, something like this.
Yep, it's 10 a.m. here.
Yeah, and in Asia it's even later. So it's a pleasure for me to announce our 10th World Spine case discussion. It's gonna be a discussion with Professor Linsler, who is on my name. Just give us, yeah, because he used my login, and he's now the chairman of the Department of Neurosurgery at the University of Nuremberg, but it's the department is in Bayreuth, so it's a very traditional place. You see all the Wagner big World Festival is there. So he's just appointed there, and he has done a lot of endoscopy in his life. Particularly, his focus is spine. And then the other faculty is Assistant Professor Zenger. He is actually the German representative of the International Society of Minimally Invasive Spine Surgery. And we will have 3 cases. Actually, we selected Dr. Spielmann's case. Where's she? Dr.
Hello.
Spielmann, just show us your video. No video?
Um,
Yeah, there she is. And we have actually a lot of cases were submitted. I think 9 cases were submitted. So we selected 3. So what we're going to do is now the first presentation I think we should do is maybe Dr. Linsler presents one case, then we discuss the case. The second case, Dr. Zenger, and then Hannah, since it's your case, you are the last to present and to discuss. Please, we are happy to discuss, so just use the chat mode for any questions. And if there's anything else, just let us know. And I think we should start with Dr. Linsler. And I mute myself, so please share your screen.
So I share, right? So can you see the PowerPoint presentation? So it's visible for you? And you can hear me, that's great. So the first case was submitted from Dr. Avamli. He's a resident in the Neurosurgery department in the Saarland University. I think it's really interesting case. It's a 94-year-old female with typical symptoms with back pain and especially much more pain in the left and the right side with a claudication spinalis with intermittent pain after some meters walking distance. She has this pain for a long time. You see that the MRI scan in 2016, so many years ago. At that time, already demonstrating lumbar stenosis at some levels. Then she did a conservative treatment, and then there was an MRI scan from 2022. At the moment, now the patient was examined. She was without any motor deficits, no sensor deficits. She had some pain the dorsal leg, both sides. No side is more affected. And in the images you see on 2016, it's on the left side. It's a severe stenosis, especially L2, 3, but also 3, 4, and 4, 5. In the sagittal plane, also in the axial slide. And I think this sign here with the compression of the nerve roots in the dural sac, more granular than the stenosis, is very typical for a very severe stenosis. And 6 years after that, it's even going more worse. You can see here in L3, L2, L3, the stenosis is more right side is very, very severe. Also, 3, 4, 4, 5 is not. There is some suitable that is. We had also a CT scan with some signs of osteoporosis, especially level 3, 2 and 3, 4. But there's not so much bony deficits or bony some aspects 4, 5. But of course, there is probably some very, very small listhesis L4, 5. And the facet joints don't look that really very nice. So he sent 3 questions. The first, I think, the most discussable. What's the best indication here? Decompression or decompression with fusion? And after that, the decompression should be done endoscopic or microsurgical, the standard approach, but the risk for instability is it higher if you do endoscopic procedure. So, well, that are the questions. So, I would recommend in this case, then we can discuss. For the first question, I recommend only a decompression, not a fusion. But I think it's really discussable. But for me, there's no, the leg pain is more dominant than back pain. And even if the facet joints have some affection, in this age, it's younger than 50-year-olds, I would prefer a decompression. Are there other remarks or comments to the first question? Or other ideas, concepts? Well, I think this questions you can discuss a lot.
Yeah, so Stefan, thank you very much for the case presentation. I agree in that I first would recommend decompression alone, but I would hardly discuss the case with the patient, as we see the ongoing degeneration in the MRIs when we compare 2016 with the current MRI, especially in the level of L4-5, we see a ongoing degeneration, and the patient should be carefully, the informed consent should be very detailed, that it might occur in the next few years that there might be a fusion necessary after the minimally invasive decompression. Of course, but my first choice were also only decompression.
Yeah, I think the age of the patient will be very important, because if you do now a fusion, then the question, how many levels? 1, 2, 3, and then for sure you have 5 to 10 years later a vision surgery, the next level. So I also think that the patient will have, she needs some treatment in the future, but at the moment, the decompression might be the best choice. Then if you use the decompression, the surgical is much better than the microsurgical, because it's a microscopic procedure, it's a tubular system, you have a very good view to both sides. You can perform with a very small incision, a decompression, very medial, and the facet joints are not too much destroyed. So the risk for instability is lower than the microsurgical procedure, in my opinion. So what do you think, Joachim?
Well, I think this case is a patient with severe lumbar degeneration. It's unusual. It's obviously a very thin patient. You see there's no obesity, but you see a lot of progress in these 6 years. So this is a difficult to treat successfully in any case. In my opinion, probably it's better to do just decompression. The risk for instability, actually, I don't think that it makes a big difference for instability if you do 2, 3, 3, 4. I think the only risk for instability is 4, 5, because all the other segments, they are more or less fused already. And well, but 4, 5, it's not that severe. So why should we address 4, 5 if this is the best segment? So probably I think just simple decompression is good. If the risk of instability is really higher with open, I don't know. I think there is for 2, 3, 3, 4, there's very minimum risk for subsequent instability. It's only a 4, 5, and this is rather a matter of time. So when, just the osteochondrosis is progressing, then a matter of surgical strategy, I think. And I agree. I mean, the smaller the decompression area, so the smaller the approach, the less likely it is that you have postoperative instability. I think that's a good argument to do unilateral decompression with undercutting to the other side. What was the third question, Stefan?
That one was the risk of instability is higher with endoscopic procedure, but where we discussed this already.
Yeah, the other one was open decompression versus endoscopic decompression. Okay.
Well, I think it depends on your experience. If you're experienced in both or you are very experienced in endoscopic decompression, you can do that. But if you're not experienced in that, you have to do it microsurgical.
Yeah, I think, of course, if you have, the endoscopic decompression in such a severe stenosis is much more difficult than it is prolapse. So if you have experience with the technique, I think it's the technique of choice. But if you have no experience and you just there's a higher risk to get less favorable result with the decompression, more likely to have a CSF fistula and then maybe nerve root injury, then open is the procedure to go for. I think the long-term difference is not very much. The short term, of course, if you have a very small incision, the recovery is faster. So if you are sure you can achieve the same long-term result, then go for endoscopic. If not, rather do the open decompression. Sebastian, any comments?
Yeah, I also think that the risk for instability is not higher within endoscopic surgery, but in such a case, when we assume that maybe we have to come back to surgery a few years later, maybe one benefit of the endoscopic approach might also be the lower scarification. What do you think about this?
The lower what?
When we have less scarification due to our endoscopic approach, when we have to come back in a few years, maybe to perform a fusion.
Of course, the more tailored the approach is, the better it is for, the less scarring you will have. But difficult to say what this is, this will matter in the future. I think the difficult thing in this case is to select the right segment, because L2-3 is an unusual segment for clinical symptoms. It's usually 4-5-5S1. This is 90% of the symptomatic segments. So this is the first thing. And then 3-4, 4-5. 4-5, you have suspicious instability. 3-4 is also some narrowing. And you saw the progress in the 6 years. So difficult to make judgment. What do? You just do 2-3. I think we should know more about the clinical symptoms. If I remember, I think I remember that case right. We did a couple of segments in the first surgery, but I'm not sure. But we did not fuse, I think.
Are there any questions from the other one?
Any questions from the chat members? Ask them now. Maybe a remark about, we have some friends from Asia. I saw somebody from Indonesia is logged in. What do you think about biportal? Maybe Sebastian or Stefan, because I think this is an option. It's easier than uniportal. But in my opinion, this is rather less evident that you have this advantage. What do you think?
Yeah, that's true. From my opinion, in my hands, monoportal is good enough. I think with the tubular system as we use it in Hamburg, or as I use it now, you can do a good decompression for both sides of this. So, for my opinion, there's no need for biportal approach in the spinal surgical decompression. But of course, I know there are other opinions, but that's my opinion.
Yeah, and I think also in such a non-obese patient, it's quite easy to access 2 levels with one skin incision. So I don't see any need for biportal approach to have a higher variety of your access and approach. So I agree with Stefan. Yeah.
Well, in my opinion, there's no evidence so far from my knowledge, but I think we lose the big advantage of using a tube system with respect to infectious rates. The biportal technique, you more or less bring your instruments through the skin. and you will touch the skin. So I think the likelihood of infection will be much closer to microsurgical standard approaches than with the tube-based systems. But to my knowledge, there's no evidence for this, but just from my perspective. So any questions from the audience? No questions. Okay. I think then we proceed. Thank you, Stefan. It was a good case. Then we proceed with the next case. Sebastian, you present
Yes.
the next case.
So let me share the screen. You can see it. Joachim, you can see it?
Yeah, wonderful. Good.
Okay. So this case is presented by Dr. Lepchikov, one of our senior residents, and the history of the patient shows that he has left-sided cervicobrachialgia over the dorsal side of the upper and lower arm, weakness in the arm flexions since the beginning of March, and he was conservatively treated in an orthopedic department for a few days. They performed an MRI scan and saw a disc prolapse on C4-5 on the left side, and we saw in the examination a mild muscle deficit, grade 4, from the left biceps and deltoid, and no sensory deficits. He was slightly restricted in his spine rotation to the left side. And these are the MRI images showing on L4-5 this not small disc prolapse. Already some degeneration on the lower parts of the cervical spine, and a normal wide spinal canal. So this is the additional CT scan with a mild bony stenosis, and but not that many degeneration with this 47 years old patient. So what are the questions for the board? Would it be possible to have an endoscopic Frick-Holm procedure in this case, or should we perform an ventral ACDF? Then when we would decide for a ventral approach, is it better to implant a disc prosthesis or go for the fusion? And should we, or is there an increased risk for a C5 paresis after dorsal endoscopic approach?
Well, this covers a lot of difficult issues.
Yeah.
So maybe you comment first on whether you should do endoscopic Frick-Holm or fusion. This is already, one afternoon on debate. What do you think?
So, of course, in general, it might be possible in a experienced and skilled setting. You can go by a dorsal approach here, and if it's a soft, fresh disc prolapse, you can achieve a decompression of the nerve root also by a dorsal approach. But the case selection should be very strict and limited. So if it's a ongoing symptomatics over a long time, and you should or could expect some scarification of the disc prolapse, it might not be possible to get the disc safely out without too much manipulation. And of course, as we know, the C5 root is mandatory for our deltoid muscle. Too much manipulation might be harmful for the patient. So, but it could be possible. Of course, if you're not sure, a ventral approach and ACDF in the level have very good clinical results, and might be favorable if you're not such experienced with this procedure. What do you think, Stefan?
Well, I think in this case, this level has a lot of degeneration, especially in the CT scan. You see that there are some bony structures or there are some the facet fine. This also might have some osteophytes. You can do a decompression from dorsal, of course, but I would prefer ACDF. But I think this segment is not healthy anymore. And if you do only decompression from dorsal, there's a high risk that there will be a future surgery probably in some years again. But of course, you can discuss with the patient and you can, he can choose probably the approach from dorsal or from anterior, but I would recommend more the anterior standard ACDF in this case.
Can you go back to the MRI? So when you look at the MRI, you see that the level 4-5, there's a severe osteochondrosis, the height decreased, you see osteophytes, and now you go back to the CT. And you know, when you look at this CT, actually the osteophytes don't look that pronounced, but you still see them. So in my opinion, probably there might even be some aspect of a set pain or something. I think it's probably better treated from anterior. But on the other hand, there are a lot of colleagues particularly from Asia, who do a lot from posterior. So difficult to say. I think I would approach the patient, explain the patient the options. My personal preference would be anterior, also because you see that there's a disc height decrease, so you can regain the disc height. It's and just by regaining the disc height, you already open up the foramen. So I think the likelihood of a good result, long-standing good result, might even be a little better with anterior.
Yeah. And I think that already also answered our second question to go for a disc prosthesis. I think due to the signs of degeneration, I cannot recommend to do a prosthesis here, because we knew that disc prosthesis on cervical spine should only be limited to a very specified small amount of patients, carefully selected patients, series with young patients, no signs of degeneration, maybe more single-leveled orientated. So this would be my comment on the questions using prosthesis here.
Yeah,
I think it's a good question.
Yeah.
So it's a good question, but the perspective now is different from maybe 15 years ago. You know, when there was the starting of putting in cervical prosthesis, this would be a typical case where we actually put in a prosthesis. Why? Because you see 3-4 is nice, looks healthy. You look at 5-6, looks quite good. So you have only 4-5 with a severe disc height decrease and osteochondrosis. So, and the patient, if I remember that right, had not severe neck pain, right?
No, more cervicobrachialgia.
Yeah. So that would be a case we would have put in a prosthesis maybe 15 years ago. I'm pretty sure about that. But the long term is not that they all, you know, there are two options. If you have it mobile, then it's good. But you know, I think the likelihood that this is going to fuse is extremely high. It's probably 95-99%. And then you basically have an ACDF. You don't have a prosthesis, arthroplasty.
Yeah.
Sebastian, what are your experience?
You mean Stefan?
Stefan, sorry, yeah.
That's the same. When I remember when I was a resident, there were a lot of cases which have been done with prosthesis, and then we have seen after 5 to 10 years that was not the best idea. They are not so happy. And I think nowadays the indication for prosthesis, there is some indication, but not in this case. Only in very young patients with only fresh, soft disc herniation, we recommend the prosthesis. On other cases, we know that the SDF had a very excellent long-term outcome.
Yeah, this is the other aspect, that we have with the cage infusion, anterior plating, and cage implantation. We have excellent long-term results. I mean, really long-term, like 20, 30 years, because it's an old, very traditional procedure. So it will be difficult to be better than anterior ACDF in this case, I think.
Yeah. Comments from the auditory?
There, Indonesia is stocking. If we use anterior approach in the case, should we use cervical plate? What do you think?
I would recommend plating, just because we have a quite good structure of the bone, and it's not such a strong neck. But when we look at the other segments, there is an ongoing degeneration, and I tend to do single cage fusion only in young patients. Of course, if you use plating, you have to be careful that the plate does not touch the upper or lower adjacent segment, because this would cause additional rapid degeneration of these segments. But I would do ACDF and plating.
Stefan?
Yeah, that's a good question. I also would recommend, but I think it's only because I'm used to do that. To be honest, I think there's no real hard indication for that. If you look in the literature, I think the results are similar. If you use a plating or no for one level, I would say it's the same. It's just how you do it always. How do you used to do that?
Yeah, I think it's a very good question. So I think there are 2-3 different aspects. So one is that all 3 of us were trained in, where Caspar grew up. So we are used to plating. So there might be a bias. The other thing is the plate, if you sacrifice the end plates, no matter what kind of cage and what kind of plate you use, the plate will not avoid graft subsidence if you have too much taken of the end plates. But in the long term, when we compared plating versus non-plating, we had a little bit better results with the plate with respect to adjacent segment degeneration and resurgery. I think it was about 3 or 4%. You can just look it up. Fabi, you can just look it up in our papers. I think it's a little bit, maybe 4 or 5 years ago, we did the long-term follow-up of ACDF plus plate versus ACDF alone. And then, of course, there's another issue. I mean, if you have a patient who has to pay the implants, is it required to pay the plate? The plate might be another, at least in Germany, it's another 500 euros something. Is it worth it? I don't know. So it's probably not mandatory. I think if you have everything at hand and it's you want to offer the best treatment, probably it's a little bit better, but only if you're used to the plate. Does this answer your question, Fabi? Good, perfect.
You're welcome.
So there was a third question, right? A third question for this case or not?
Yeah.
What was
How
the third one?
about the increased risk for C5 paralysis? I mean, of course, it as the nerve roots are exiting very in a nearly 90-degree angle, it might be difficult to access prolapse, but with careful preparation, it can be done. Of course, you have to keep that in mind. Yeah.
I'm not aware of a study where actually endoscopic posterior decompression has a more increased likelihood of C5 nerve root injury compared to the anterior approach. I don't know that. I'm not aware of there has been any study to address this issue. It depends on your surgical technique, but usually the drilling, when you open up and you take the osteophytes, I think it's more likely from anterior that you have some heat contact with a nerve root than from posterior, because from posterior you drill a lot, but at the end the decompression is done with a Carrison punch. Whereas from anterior, I think most of the foramen is opened with a diamond burr, at least in the technique we use.
Yeah.
But as I said, I'm not aware of any randomized study. I mean, C5 is a very sensitive nerve root, but it remains sensitive regardless of from anterior or posterior approach.
Yeah.
That's true. Yeah. I also think so. Yeah. If it's narrowed, then it doesn't matter if you come from anterior or posterior.
Okay, guys, any other questions from the auditorium? No questions? I think then we move on. That was a good case. So we had a significant progressing lumbar osteochondrosis, and then we had a endoscopic posterior procedure where there's ACDF. Now let's see what the selected case for a resident presentation is today. Dr. Spielmann, it's your turn.
Yeah.
You can switch on your video.
Yes, I can't share my screen.
Just below in the middle.
Ja, dann kommt irgendwie Systemeinstellungen und ich kann das gerade nicht freigeben. Kann jemand anderes vielleicht meine Präsentation öffnen?
1 second, I will try.
You have the presentation, Sebastian?
Yes.
Just show it and you can comment on it.
1 second, it's loading. I think I have them on my folder.
I have it. I can share it.
You have it too?
Okay, just go ahead, share it.
Okay, so now you should see it.
Yeah.
Okay, great.
Okay, perfect.
Okay, you can start.
Okay, so the last case is a 66-year-old male patient presented to us due to severe lumbar-ischiatic pain persisting for 2 months. The conservative therapy did not bring an improvement. Additionally, he reported severe sensory disturbance in the left thigh. The MRI showed an extraforaminal disc herniation L3-4 on the left side. In the examination, we saw a 3 plus or 5 paresis of the left hip flexor and knee extensor, as well as hypophaesthesia in the area of L3 on the left side. In the MRI on the next slide, you can see the picture. And another one on the next slide. Okay, and then we have the questions. So what would you do? Would you do endoscopy or microsurgery, and where do you see advantages?
Okay, go back to the first MRI maybe. So the patient has 8 out of 10 pain. For how long?
For 2 months.
2 months. And it's corresponding, and he has weakness, significant weakness, right?
Yes.
Okay, so what are your thoughts, Hannah?
Well, I would do an easy-go operation, so an endoscopic operation for the patient.
So easy-go means it's a tube-based system, an extraforaminal approach or interlaminar approach. Extraforaminal probably. You know, it's extra of the foramen. Would be an option. So, Dr. Linsler, what would you do in your new setting? Bayreuth Nuremberg University. What is your equipment like, and what is your preference?
So I think it's an ideal case for extraforaminal approach, not coming from the midline. If you go from extraforaminal, from far lateral, I think then the pure endoscopic systems are the most fast procedures, the most easiest one, if you have done some. So also no microsurgical, of course it's possible with a microscope or with a tube system, but with a pure endoscopic system, for example, with Maximo Spine or Spine Tip from Storz, or but there are different companies, the technique is more or less always the same. We go from far lateral to the disc herniation, remove that. And I think it would be the best option in this case.
Yeah, it's 3-4, so it's good to approach. You know, 4-5 sometimes is difficult. 5-1 sometimes is very difficult. 3-4 is ideal. I agree, and it's a huge disc prolapse, so it should be quite easy to approach. What do you think, Sebastian?
Yeah, I agree, because it's with the transforaminal approach, it's straightforward. It can be done in 30 minutes. We have no issues with the iliac crest in our way, and it's a acute symptomatics only for a few months. I think we can help the patient a lot, and it's a 10 millimeter skin incision with spine tip or any transforaminal full endoscopic devices. In my opinion, also the best option. From a dorsal approach, it might be difficult to safely access it in such a short time and with a comparable result. I mean, of course, if you're familiar with it, no way, but I think best choice is transforaminal.
So there's a question from Dr. Digyanis, whether it's possible from interlaminar, so more medial endoscopically than not transforaminal.
The question is there, does it mean for medial as a standard approach? Then I think it's really difficult because you've destroyed the facet joint.
Yeah, you sacrifice a lot of your structures to access it, but because also in a microsurgical approach, you would aim for a lateral approach coming from lateral from the facet joint to spare it.
And there was another question for Dr. Fenus, where I think this explicit said, what does Jason mean? Transforaminal, extraforaminal? Where is it? That's the definition there.
Yeah, we approach the foramen, so it's not trans, it's foraminal approach. Probably it's an interforaminal, extraforaminal disc prolapse. Actually, we use basically always the same approach in our hands for extrafemoral and interfemoral and transfemoral. It's not a big difference. So all these different ideas about being more lateral, being more medial, we don't address that much as some from, I don't know where you're from, Andrew, but from Asia, they have even different scopes for the interfemoral and the transfemoral. So in our hands, that's more or less similar. So we just do the difference between interlaminar endoscopic and extrafemoral, interfemoral, transfemoral. And one more remark for Jason de Giannis. In this case, probably is difficult, but there are cases you can come from interlaminar, and you can just if it's a not perforated disc prolapse, if it's a contained disc prolapse, you can just press with a dissector and use the dissector to push down the contained disc prolapse, and you can extract it via an interlaminar approach. I think here it's not possible without sacrificing the facet, but it's possible in many cases without sacrificing the facet. But probably this is too big and too much, and this is a sequestered disc prolapse. So I think this will be very difficult to do from interlaminar. So then,
so they're coming
oh,
some.
but Andrew, what is the difference for extrafemoral far lateral or transfemoral transcumbine? This is always transcumbine. The only idea is once you open up the disc or not. The transcumbine triangle you always have to address. It's not a difference. Okay, so I don't exactly, well, this is too much into detail now. I mean, they're basically two principles for the transfemoral extrafemoral technique. So one is you enter the disc space and then you retract, so the inside out technique, and then there's the outside in technique. And this is, I think, in my opinion, the difference is subtle. If you have not that much experience, it's probably easier to start with this discography and then pull back. In such a case as you have here, I mean, you have already perforated disc annulus, so there's no reason to preserve the annulus. I think it's possible to do from inside out. And in another case, sometimes, yeah, you might come from extrafemoral, but I think it's rather a little bit surgical by different surgeons advocated, but I don't think that this is a big difference. And of course, for TLIF, you put in the cage if you want to do a TLIF, but this is at least the cages available for us, they don't fit the Cumbines triangle. So this is usually then not transfemoral. Okay, so yeah, this is but this is the terminology. This is driven by the different companies. I mean, what do you think is the difference? This prolapse, it's exactly where you have the perforation. It's exactly the same anatomy. But for TLIF, if you have not an expandable cage, probably you need a more lateral approach, because then it's quite difficult. Or you do the standard TLIF. I mean, TLIF means transfemoral, so you always do the facetectomy then. Then you have enough space. Okay, there was one more question. Is a tube-based approach also an option? Well, actually, in the beginning, we have done a lot of tube-based approaches for extraforaminal. And here it's very thin patient. And this is in maybe 4 centimeters depth or 5 centimeters depth. So it's possible. It's possible, in my opinion, it's more difficult than the shear endoscopic approach. So right now, I think we would rather favor the shear endoscopic approach. Is there a big difference in the postoperative recovery? There's a little difference, but I think the wound area actually is not much bigger with the tube base because it's shorter. You just go down. You don't come from that far lateral. So if you have a 5 mm diameter and you have 15 centimeters, or you have a 10 mm diameter and you have 5 centimeters, the wound area itself remains almost the same at the end. That's a very good case. I like this case. Very good case. So what was the other question? Was there another question?
No.
Anna, what was your second and your third question? Did we address everything?
Yes.
What was your question? The second one was?
Endoscopy versus microscopy.
Okay. What was the age of the patient?
66.
66. So this patient actually has a nice lumbar condition when you think about 66 years old. So there's still some juicy fluid, good fluid content of the disc 4-5, disc 3-4. It's a very good 2-3 disc. So only mild protrusion 3-4, 4-5. I mean, 5S1, you have a significant decrease in disc height, but 3-4, 4-5 you don't have. So, well, you would be reluctant to sacrifice the facet joint, but if any reason, let's pretend you don't get the fragment with a shear endoscopic approach from the far lateral extraforaminal. Then I would still go for an interlaminar and then sacrifice the facet. I think the likelihood of a postoperative instability is not that high to, just compromise on the surgical results. So we have to take out this huge disc fragment. But so far, I think this is really, I think, for an extraforaminal approach, I think this is a good case.
Yeah.
Yeah. Any other questions? Okay, advantages. Well, advantages is for the extraforaminal disc prolapse. So the lateral approach is that you don't touch anything of the spine. The advantage is that you do not sacrifice the facet. The advantage is that you have a very, very small wound area, and you have a shear endoscopic approach, so which means that you don't have a high risk of infection. Maybe the disadvantage is that it's a little bit more difficult to really check for a sufficient nerve root decompression at the end. I think the intraoperative analysis of the results is more challenging. It depends. When you have the very small, there are so many different brands available. So if you have a very small, it's more difficult. If you have a very big, so like the Max Moore spine or so, I think you almost always know that everything is decompressed. So I think these are the advantages. It's faster recovery, and the disadvantage is maybe that the success rate is the intraoperative feedback is not as good as you do in microsurgical approach.
So, further questions?
Awake surgery. Good question.
I love. I
So
knew you
that
loved
was
this
when we
question.
started the lateral approach there and the transfemoral actually. I thought because there are so many presentations out there that you can do this in local anesthesia. And well, you can do it with local anesthesia. You can do it. It's possible. But at least in our hands, we tried a couple and we use general anesthesia now. We did a couple in local and under sedation. But then the difference is subtle. You know, when you need an anesthesiologist, then I think it's easier if you just use general and full ventilation. If you don't need an anesthesiologist, then it's difficult to monitor because it's still painful. There are cases which go very well, and then suddenly there are a couple of cases which do not good at all. So it's difficult. I think it's possible. Without sedation, it's probably very challenging. With sedation, it's possible, but if you need somebody to monitor the sedation, the difference to full intubated and on a controlled ventilation is subtle, in my opinion. So it's possible, but it's not awake as you think is awake. So at least in our hands, we always used a lot of sedation. But we did a couple. The idea I started with this with the idea that we could do cases without anesthesia. And this did not work, at least not back then. It's maybe 14, 15 years ago when we started the technique. Actually, I think we all did these still in Mainz, not in Hamburg. So it's 15 years ago. But it didn't work. So maybe we did 2 cases without anesthesia sedation and we did 10 with, so it didn't work.
And did you any with an epidural block?
So that's a different issue. You can do everything with spinal anesthesia. Everything.
Yeah.
No problem. But you still need somebody to monitor the patient.
Yeah.
That's a different issue. The difference in lumbar is you can do everything within epidural block with the spinal anesthesia. No problem. We did a lot of cases. But this is, you still need anesthesia. So the idea that you can do a case, without monitoring the patient as close as you do with your anesthesiologist did not work. Any other comment from the auditorium? No comments. So then thank you so much. So I conclude that we had a wonderful central stenosis case with a significant progression and osteochondrosis over 6 years. We did a nice cervical. Actually, I think I don't know what exactly was done at the end in this case. I don't remember that case, but I could pretend that probably if it was my patient, I would do ACDF from anterior plus plating. But I think we discussed the posterior endoscopic options, the arthroplasty options. And then the last case was a case, I think, in my opinion, the easiest case from our experience, because the advantage of a lateral full endoscopic approach for the perioperative pain and recovery is so significant that I think in any case we would try to do this with a lateral approach endoscopic. Okay. No further questions. Then I thank everybody for participating. And the next meeting, Shana, you know when the next World Spine case presentation?
Yes, it is May 19th.
May 19th, as a different team, different idea, different perspective, but still spine. Okay,
Yeah.
see you
You-
in 1
you have-
month.
Joachim, you want to give an invitation to Hamburg for September?
You have the slides there. You can do that.
No, I have not here,
Yeah.
but maybe
Okay.
you can mention.
So we have in September we have our endoscopy course of the spine module being on Thursday and Friday. And then we have the ISMES meeting, the ISMES World Conference in 2024 in Hamburg, Germany. It's actually in collaboration with the World Spinal Column Society. And it's going to be a meeting, I think it's September, let me check, 13, 14, is that right? Just
13,
correct me if
14,
I,
yes.
let me see, it's 13, 14, 12, 13, 14. So if
Yeah.
you're interested, just let us know. And yeah, will be a good meeting, I'm sure.
Yeah.
Thank you, everybody, for being with us. Have a nice Sunday.